Ready?
Oh, it looks like we're live.
Hello, I'm Nanette Santoro, a professor in the Department of Obstetrics and Gynecology at the University of Colorado School of Medicine in Aurora, Colorado. I am here with my colleagues, Dr. Richard Anderson, Professor of Clinical Reproductive Science with the University of Edinburgh in Scotland, and Dr. Joy Baker, a general OBGYN who practices in LaGrange, Georgia.
Hi, everybody. Thank you, Nanette. Lovely to be here and have a discussion about these things with you too.
Yeah, very excited to be here to talk about this very important topic.
We're happy to welcome you to this program, which is titled Shedding Light on the Menopausal Experience and Demystifying Treatment. Today, we're going to focus on vasomotor symptoms related to menopause, including how to diagnose, treat them, and how to talk to patients about treatment. At the end of the program, we'll take a few minutes to answer some questions that you may have. So we are going to begin with a patient-centric approach for managing menopause-related vasomotor symptoms, talking about what they are and why they happen. We're going to spend some time talking about demographic differences, talking to patients, hormone therapy, non-hormone therapy, and then an individualized approach to treatment. So what are they? As best we know, there's an alteration in thermoregulatory activity in the brain. Quite simply put, the brain's thermostat is located in the hypothalamus, a portion of the midbrain. And specifically in these neurons called candy neurons that make different hormones that influence reproduction, called kisspeptin, neurokinin, and dynorphin. And we're going to focus on neurokinin because that seems to be the actor that causes the hot flashes. So neurokinin goes up, neurokinin receptors on candy neurons when estrogen goes down. So with menopause and the decline in estrogen, these NK receptors go up and they transmit a signal from the hypothalamus through to the median preoptic area, another part of the midbrain, that also has neurokinin receptors that then affect the body. And the periphery, and the rest of the body and the blood vessels get triggered, and they have a sensation of heat. And heat dissipation is the way we always do it. We sweat, our blood vessels open up, but these are very sudden and severe. So that leads to the hot flashes and the night sweats. So blocking this neurokinin receptor or by estrogen action is one way to treat VMS, but they are the most bothersome menopausal symptom for many women. And they are the symptom that drives most menopausal patients to seek treatment. In about a quarter to 2/3 of women, vasomotor symptoms start before cycles even become irregular. The old thinking was that they lasted for 2 to 5 years, but new thinking is that they can last for 10 years or more. And a small percentage of women will have hot flashes indefinitely. Joy, can you tell us a little bit more about that?
So it's a very interesting phenomenon in that that the menopausal experience for each woman is very different. Some women will have very mild symptoms. Some women will have very severe symptoms. And one of the things that we've been noticing as more and more research is coming out is that Black women can have longer duration of vasomotor symptoms and can start to experience these symptoms earlier. And this is very interesting because the earlier onset of menopause, we know, is associated with the loss of estrogen, and that loss of estrogen can be associated with an increase in all-cause mortality. So I think it's really important that we're starting to really look at this and understand it. I remember my own mother going into menopause earlier, and as I became a woman of a certain age and a physician, I got very interested in looking at the differences in race and ethnicity and vasomotor symptoms. And so, so I think this is something that is going to be very interesting as the research unveils some of the underlying causes of this. Because at this point, it's not really very clear why there are these differences when we look at vasomotor symptoms based on race and ethnicity.
Joy, could I just chip in with a question to you? Where do you think Asian women fit in this graph? Because it's striking they're not included. But what's your experience of where they fit in?
Well, I really do not have a lot of Asian women in my population, but I actually attended a scientific conference over the weekend, and they were saying that Asian women tend to have shorter durations. So I think that is going to be something that's quite interesting as well as we start to look a little bit more deeply at this information and how do we actually translate this into clinical practice. But I think, it's very important to note that our Black and brown patients may be having earlier onset of menopause, more severe vasomotor symptoms, and make sure that we're addressing these issues with them and offering treatment.
And we do see Chinese and Japanese women from the SWAN study. So these are US women. The Chinese women were largely first generation immigrant women. The Japanese women were more acculturated to America, but both of those groups had shorter durations of vasomotor symptoms.
Yeah, I think that's the general perception, but it's I guess it's interesting. I guess this just reflects the population that you were able to study in the SWAN study, Nanette, is that you didn't have a lot of other South Asian populations that you could include. Is that the way it worked?
Yes, we did not. We specifically recruited the ethnic groups that you see outlined here. So we do not have other South Asian. We do not have Indian. And that actually brings me to ask you a question, which is, what have you seen in terms of demographic differences in VMS in Scotland, where you practice?
Scotland isn't the most diverse country by ethnicity, you'll appreciate. But we do have quite a lot of quite a South Asian population in terms of Indians, Pakistani, Bangladeshi populations, and it is interesting. It may be just anecdote, but I don't think they tend to present with as bad or as much in the VMS symptoms as Caucasian women do. But I wonder just how much of that is cultural as well as actually real symptoms, and that if you were to sort of dig into this in a bit more robustly, how much strip away the cultural interpretations and actually did the biology, it would be intriguing to see how much differences there were or weren't between these groups.
Would be very interesting. And there's two things that I always wonder about is that there's been, worldwide, obesity has increased in all populations, and climate change is happening, and the world's getting hotter. And I wonder if there may be some secular trends. There's been some musing in the media about whether menopause is actually worse for women of this generation than it was for women of prior generations. And those might be some reasons that this could be happening.
And of course, every time you open a scientific journal or even a newspaper these days, there are always going to be reports of environmental chemicals, which are often anti-estrogenic or estrogenic, variably, that may also impact on this.
Absolutely. And I've been very curious about some of the work that we've been doing in regards to health disparities and maternal mortality. We've been talking a lot about biological aging and the concept of weathering. And I wonder if that is also affecting Black and brown women when it comes to the onset of menopause. So just such very, very interesting thoughts and ideas and questions. And so I'm very excited to see menopause research come to the mainstream and to really become a lot more active.
Yes, and those are all active areas of investigation. So I look forward to learning more about those aspects. So how do you talk to patients about VMS, and how do you confirm the diagnosis? So when patients bring up vasomotor symptoms, how do you decide whether their symptoms are due to menopause or something else? That's a toss-up for you, Joy or Richard.
Well, could I just chip in just a first comment there, and actually is just to pick up on something that you said earlier about how they can start before obvious cycle irregularity comes along, and that then makes it very difficult because you're not going to pick up the sort of the biological or the sort of the biochemical classic menopause diagnostic tests that you would, the high FSH, the low estradiol that we're all familiar with. And so it's, to my mind, it's really just a matter of, a sensible association that at a certain age, this is the likelihood, and being cognizant that this is a possibility, being aware, I think, as a medical practitioner, that you don't have to wait until your last period before you're going to get VMS. And it's about medical education as much as anything else.
Absolutely. I completely agree, Richard. I think that we should be having these conversations with patients and listening to them and individualizing, who we believe needs to be treated. And so a lot of that is going to be based on history. What is the patient saying about their experiences? So I think that's going to be really important, especially when you can't depend on some of those biological markers that we're used to when it comes to talking about vasomotor symptoms.
And I also think when women are still cycling more regularly, meaning at least one period every few months, their hot flashes may be milder. So for some, it's actually a little bit difficult to recognize that that's what they're having. As they go further on in the transition, then they become a little bit like, pretty obvious because they get more severe. But when you have patients that are in that perimenopausal age range, but they don't mention symptoms, how do you approach that conversation? Do you elicit symptoms? Do you ask about them?
I do. I believe in asking about them. And I also believe in providing anticipatory guidance to my patients who are in that perimenopausal age group. Because, if we are proactive about it, it tends to sometimes just knowing what to name something when it happens to you can be really.
Oh,
Oh, I think we've lost you for a moment, Joy.
And I'm saying,
oh, she's back.
oh, I'm sorry. Can you hear me now?
Yes, we lost you for a
Am
moment.
I back?
You're back.
Oh, sorry. So I was saying that I certainly believe in asking patients about any menopausal symptoms and providing anticipatory guidance. Because I think that sometimes knowing how to name something that's happening to you can be really helpful. And then patients are much more likely to come back and say, you know what, you talked to me at my last wellness visit about vasomotor symptoms and hot flushes. I think that they're happening now, and I'd like to explore treatment. So it really does sort of open the dialogue and start that conversation. So I think proactively talking about this and asking about it is really a great way to approach this with patients.
How do you assess whether someone's having mild, moderate, or severe? How do you get an assessment of the severity from your patients?
So I usually ask them, if they do endorse having vasomotor symptoms, how often are you having them? And just sort of get a history from patients. It's hard to get patients to complete diaries these days, like we used to do back in the day, but just asking them to sort of keep count. And then does that individual feel that these vasomotor symptoms are affecting their quality of life? And so based on those things, we can get to an idea.
Sorry to interrupt there, Joe. I agree. I think it's very much a subjective thing, isn't it? And it's a matter of how much it impacts on the patient's quality of life, essentially. And what might be severe for one woman is not so severe for the next. But if it's impacting on her sleep and her ability to get up in the morning and do her work or interact with her family in whatever way, then it doesn't have to be necessarily what an FDA trial would regard as severe to be having a severe impact on her.
I agree. I mean, I kind of think, mild R, it would be nice if I didn't have them. Moderate RG, it would be really nice if I didn't have them, and maybe I need to do something. And then severe, my patient's coming in saying, I need something now. I've had it with these. That's my little sort of thumbnail way of doing it.
That's a great mnemonic. We'll try and remember that one.
Let's move on to hormone therapy. So hormones are the recommended first-line treatment for vasomotor symptoms, and estrogen is the standard. And it's valuable for low-risk women who don't have heart disease or low risk of heart disease and do not have contraindications. The most common ones can be history of thrombosis or prior breast cancer, and some women at very high risk of breast cancer, it's better to use an alternative. In general, use is limited to women who are younger than 60 or less than 10 years from the onset of menopause for maximum benefit to risk ratio. In women with a uterus, you always have to combine systemic estrogen with cyclic or continuous progestin or with a SERM to reduce the risk of endometrial cancer or hyperplasia. And there's various oral or transdermal hormone therapies that have been approved, and newer therapies that combine what we call bioidentical hormones. And all of those work. They are approved for vasomotor symptoms and not to prevent postmenopausal bone loss. And I'm actually,
Nanette, while we were on that topic, would you just comment a little bit about the bioidentical hormones? I think there's a lot of confusion, even amongst clinicians, about bioidentical versus compounded hormones.
I agree. So because bioidentical isn't a real word, it was kind of a made up word for marketing purposes, but it's in our lexicon now and we need to deal with it. I tend to define it with my patient when I'm in the office. I say, by bioidentical, this is what I am saying. Is that your understanding? But that really to me means something that's molecularly identical to the hormone that is circulating in a woman's bloodstream. So 17-beta estradiol and progesterone are bioidentical. They are made now in pharmaceutical preparation. So they are FDA-approved pharmaceutical grade. So there's very little reason to need to ever compound these hormones unless someone is allergic to every preparation you have tried. That would be a reason to compound. But other than that, there's a very limited use for compounded hormones. And in fact, the National Academy of Medicine has clearly come out against this and recommends against their use because they are not FDA approved. They do not have the same standards of manufacture, despite the extensive advertising that they're better.
I agree. I think the term bioidentical is really unhelpful, isn't it? It obscures the fact that these are. I mean, in our practice, in the UK, we tend to have used less of the non-bioidentical hormones historically. We've used estrogen itself for more widely for longer than, for example, the Premarin type preparations. But yeah, it just obscures the issues and makes people think that other drugs, that other tablets, and is this a safe thing? Is this a dangerous artificial hormone? When of course, in the great majority of cases, it's a very well safely tested and tried synthetic progestogen or natural estrogen.
Yes, and I think it's important to say that these are FDA-approved compounds. There's a lot of data on their safety. So we know a lot of the good and a lot about what are the bad. So it's very, it's not a huge task to balance for an individual patient what her benefits and her risks may be. There's also for women who do not tolerate progestins, there's a newer hormone therapy that combines conjugated estrogen, which is not bioidentical unless you're a horse, with basidoxifene, which is an estrogen receptor modulator. And that has been shown to be effective against hot flushes, improves bone mineral density, things that we know hormone therapy does, and also cause less breast tenderness or bleeding than the more traditional preparations.
Yes, I
However,
find that patients tolerate that very well, especially folks who, just were not doing well with the progestin. So I think that's a really good point to make.
and just to review about the reluctance to take hormones, Richard, I'm going to have you walk us through this, but hormone use fell very sharply in 2002 after the Women's Health Initiative results were published.
Yeah, I mean, it was a real tsunami, wasn't it, that went through our practice and through medicine generally, and indeed through the pharmaceutical industry. Back in the late 90s and around the turn of the century, there were a lot more companies involved in the field and then suddenly they were all just swept away. And it's interesting just to look back on it now, and with a 20 years of hindsight and just see what a real disservice it was to women's health in practice in many ways. And I remember at the time colleagues being almost pleased to see problems sometimes in this, and had been a bit overwhelmed by the fact that HRT was being so widely marketed as a positive thing for women's health, and then they almost sort of relished the fact that then it was all sort of washed away. And I think it's taken us such a long time to get back to any sort of equilibrium. And in fact, we're obviously not really there yet. It will take longer to get over this. But we are seeing, I think now, a much more moderate and balanced view coming out across, medical practice in this field.
What I find very heartening is that the clinical guidelines really worldwide are now in very good agreement about how these results should be interpreted. And really, it's so unfortunate and still the topic of much, head scratching, how hormones became so stigmatized, because the risks of hormones that we saw with the Women's Health Initiative were exactly as predicted and expected for breast cancer, exactly as predicted and expected for blood clots. What was not expected was that there was not a benefit in reducing heart disease. And that was the purpose of the Women's Health Initiative trial. It did not show that benefit. So that stopped being a reason to treat women with hormones, because it was not going to prevent heart disease. Yet all these symptomatic women who began, having hot flashes away and all other symptoms related to that would have been better with hormone therapy, stopped taking it out of fear. Yep. So that's just terribly unfortunate. I think a lot of that is misinterpretation of the data.
Yeah, and it just shows how a bad name sticks for such a long time, doesn't it?
It does. It absolutely does. And there's so many women, even now, I'm a general OBGYN in a small town in Georgia, and I see patients every day who could benefit from hormone therapy. But, it takes probably 2 or 3 visits for me to really lay out the data and allow them to make a decision about how they feel about it, because they sort of have been indoctrinated that hormones are bad, hormones are dangerous. And so it really becomes a very important conversation. And then too, even in the medical community, I think there's still a lot of confusion about the Women's Health Initiative and what it actually means. And so I just always put the plug out there to educate yourself so you can educate your patient. I mean, I'm not a reproductive endocrinologist by any means, but I have made the effort to get that education so that I can make sure I'm offering the appropriate treatment options to each patient.
And I think the other aspect, Nanette, that is so important about WHI is how it didn't include the patients who we normally see every day, who are in the perimenopause or early menopause. It wasn't including that particular group of patients. These were older women who are a very different situation.
Right, because the question being asked by the WHI was a different question.
Yeah.
So it didn't make sense at that time, but not effective for heart disease, but surely effective for symptoms. So very frustrating. So one of my words of advice, and we're in a social media setting, spread the word. It's not necessary to commit to hormone therapy for life. Women who think it may help them should try it for 3 months, because then you yourself will know what the benefit is. Like, how is this helping me? I feel much better, or I don't feel much better. Then you know what to do. But I can't just tell you about risks when you have had no benefit. You can't balance that equation. And 3 months of hormones pretty much never hurt anybody. So it's pretty low risk to just give it a try. You don't, as I say to patients, you don't have to marry them, just date them for a couple of months and see.
I love that. I'm gonna steal that, Nanette.
Feel free. So I want to spend the last couple of minutes talking about non-hormone therapy for vasomotor symptoms, because we do have some other options. This is a very busy slide that has all of the non-hormones that we know of them. One is highly specific and has been FDA approved, fezolinetant. The other is in the SSRI antidepressant class, paroxetine mesylate, which is FDA approved. all of these other medications were found by serendipity to improve hot flashes. So women who were taking them for another medical indication said, oh, my hot flashes are better. What did you give me? And then they were systematically tested. So most of these have withstood the test of time. Some of these on the bottom have been considered not advised by the Menopause Society for being less effective, but some of them are worth considering if hormones are off the table.
But I think the other points as well to make about this is that actually they're not brilliantly effective. And they are sometimes a bit effective, but these are not drugs that you can give to a woman and say, I know this will make you better.
Yes, and the other problem with them is that they have off-target side effects. So
except for perhaps this class that you're now bringing up.
That brings us to the
Perhaps
NK3 receptor antagonists. So back to you, Richard. What makes fezolinetant different than these other non-hormonals?
Well, I think these are potentially a really interesting and game-changing collection of drugs, because there is more than one of them. There was a new study just came out this week of a different one from a separate company. Obviously, a drug that's not licensed as yet, but targeting the same pathway. And I think what's interesting about these drugs is that, as you showed on your pathway, they have a relevant and known specific action in this sequence of events that results in the hot flashes. So, we understand how we think we understand how they work to do this. And you can also see in this picture you've got here how they've got perhaps two sites of action, one after the other. So they're acting on the candy neurons and acting on the thermoregulatory, the vasomotor neurons as well. So you've got an effect and then a further effect. And I wonder whether that actually helps make understand some of the data that we see from these drugs that see such a rapid and really quite dramatic effect in many women. Not all women, but many women can really be seeing an effect on their hot flashes within just a couple of days of starting taking these drugs, which is really remarkable. So yeah, as I say, we have one of these drugs is already available. Another one probably coming along soon. May well be others, and it'll be really interesting to see what these do and how they have a place. But I think one of the things, of course, they don't do is they don't provide all the other benefits that estrogen does that we didn't really go into, because we are very much focusing on the VMS today in this chat. But I think this is important. But this is a very specific VMS targeting pathway that perhaps now we have some really good tools to get at. So I think it's exciting days for the field, actually.
I agree. And yes, we just had a new publication on the next one that's going to come, and that is a dual NK1 and NK3 blocker. Both fezolinetant and elezenitant is the newer compound, seem to be effective against hot flashes and also show some benefits for sleep, which is very interesting. And I want to just backtrack a bit and go back to patients who don't want any medical therapy, who aren't candidates, or for whom treatment doesn't work. What strategies do you recommend for patients in those categories?
So I do see quite a few patients who prefer to avoid medication use. Initially, usually at some point, we do think about either a hormonal or non-hormonal option for them. But, there are all the things that we talk about in terms of lifestyle changes, trying to include more plant-based in your diet, regular exercise, avoiding caffeine. So there are all sorts of lifestyle modifications that folks can do. The efficacy of that, but I think that it's very important to take that patient-centered approach and to hear them and to talk about what it is that that they want, and then help them make decisions if what they're doing is not helping. If they are taking, there are lots of over-the-counter supplements that are on social media now that folks are researching on Google, and so they're doing these things. But I think that it's very important that we try to offer some guidance, and that we make sure that our patients feel heard and seen, and that we are sort of helping them with shared decision making, but allowing them to make their own decisions when it comes to the treatment option of their choice.
I think that's fantastic, Joy. And I think you know, some of these things, some women do find significant benefit from them, don't they? I mean, you mentioned caffeine, but alcohol is another one that's some women
Yes.
find it's just not worth having that glass of wine of an evening because you're just not going to get a good night's sleep, and you know, that can be you know, quite a big game changer for some people.
Yes, absolutely. So
Yes.
for those who decline medical therapy, you know, just lifestyle modifications can be helpful. And then I usually follow up closely with those folks, maybe in 3 months, and just see, well, how are you doing? And are there, you know, is this a point where we might want to consider a medication therapy, either hormonal or non-hormonal?
So just to wrap up, because I want to leave a couple of minutes for Q&A, we have found, and it's been seen, that a sizable proportion of women who saw a doctor for vasomotor symptoms never got any prescribed treatment, and that's just shouldn't be done. Furthermore, there's a health disparity because we've seen that populations of color tend to enter menopause earlier, more likely to have more severe or longer lasting vasomotor symptoms, yet they are less likely to receive treatment. To make matters a little more challenging, we know that hormone therapy is effective, but many women are averse to it. But they may be candidates for other options, which we've also discussed. So helping women to optimally manage their vasomotor symptoms, I hope we've communicated to you, requires shared decision-making and an individualized approach. And thank you for your attention, and we'll move on to any Q&A. So I'm going to move
Wow.
out of presentation mode. So far,